Thanks, Rinky. I've been asked by Jim to give this talk as chair of the, as current medical director of the Heart Foundation. But I wear a number of hats in New Zealand, have done for a wee while. I'm just about finishing my 20th year as a practicing cardiologist in Waikato District Health Board. That's Waikato Hospital that you see there in the background. And I've been involved in leadership in cardiology for about 15 of those years, both within Waikato and across the Midland region. Those of you that know the geography of our regions, the Midland region is one of the most complex that we deliver tertiary cardiac services to in the country. I think we forget to actually stop and celebrate success. And I think if I look back over the last 15 years, we have seen significant improvement in our management of cardiovascular disease in the Midland region. And I think we've actually got to acknowledge that at times. You know, we now get people across to Waikato much quicker when they present with acute coronary syndrome than when I first started. People would often wait up to 2 weeks. They now come across within 3 days for the vast majority of those people, irregardless of where they are, be it Taranaki, be it in Tarafiti. And I think, you know, our nature is we strive to do better as clinicians and scientists, and that's a good thing. But sometimes we've actually got to acknowledge where we are, and I think that's really important. So with that, just to set the background where we are with cardiovascular disease in New Zealand. This is a slide that many of us have in our slide portfolio. And as you can see, since at the end of the 1960s, when the Heart Foundation came into inception, we had an epidemic of heart disease. And since then, we've had a dramatic, a stellar reduction in the burden of heart disease deaths across our country. And Rod, it's not all due to reduction in saturated fats. There's other things that we've done during that period of time, better prevention, public health strategies, and also what we do when we see patients when they present with heart disease, be it revascularisation or other medical therapy. Just to emphasise this, and Jim, I don't think you were practicing in the 1940s, but perhaps in the 1960s. But this is about science, and this is where science has got us with how we manage acute myocardial infarction. So look back to the 1940s. If you come in with myocardial infarct in the 1940s, you had a 50% chance of dying. Probably not from your infarct, but probably from pulmonary embolism as a complication. You've been stuck in bed for up to 6 weeks. If you fast forward to where we are in the 2000s, where we are now, the mortality from an ST segment elevation MI, that's someone for the non-medics in the audience who come in with a big heart attack, it's about 4%. So that's a significant reduction. And we're not going to see trials that are going to reduce that much further because of the magnitude of benefit that we have currently. What is important, though, is applying the evidence base. We know about 1 in 3 people in New Zealand, when they come in with a heart attack, do not get either clot-busting medicine or angioplasty. So why is that? What are the barriers to us delivering optimal care to New Zealanders, regardless of where they live? Again, we need to do better. If we look at acute coronary syndrome, so this is when someone comes in with a heart attack or a suspected heart attack, and this is more contemporary data from 2006 to 2013, we see a 26% reduction in admissions with an acute coronary syndrome. At the coalface, I don't think it's changed that much, but we are certainly seeing less patients coming in than we have done historically. What's also important is the people that we're seeing are different. 50% of the people we see now have been in hospital previously with a previous heart attack or a stroke or some other cardiovascular disease. Okay, so the people we're seeing more likely to have had a previous event, more likely to have other things going on, and more likely to be older. If we look at our management, and this is looking at comparison from 2006 to 2007, 2012-13 using the ANZAC QI database, our use of revascularisation strategies through bypass grafting or angioplasty has increased across our country. But what you can see there still is inequity of access to some the revascularisation is shown here. And I could show you a similar slide for access to see cardiologists around the country. We still have issues with equity. So what's the problem? Well, if we look at our mortality, yes, it's reduced. But if we compare ourselves with other contemporary societies, OECD countries, Australia here I've illustrated, We have 40 more deaths per 100,000 in New Zealand than Australia. So that shouldn't sit lightly with us, and nor does it. We've talked at length about inequalities during the meeting, and that's across generations, ethnic, socioeconomic groups. Need to stress that as well. It's not just about ethnicity. There are other drivers for why we see inequalities in our country, and that does not sit well with us. Heart disease remains a leading cause of health loss in New Zealand. If you see, this is data from the Ministry 2016, health loss up to 2013. Coronary heart disease is the leading cause of health loss in males and the second leading cause in females. 1 in 3 of us will still die a cardiovascular death in New Zealand, and a New Zealander dies every 90 minutes still of a cardiovascular death. So again, we need to take this seriously. It's not gone away. We're also living longer, that's a fact. We're also living longer in good health, but we've got an ageing population. Because we're living longer, we are going to have more time spent where we may develop ill health as well. So we've got a challenge to help our ageing population live well with cardiovascular disease. The disease that we are already seeing, as we're seeing much more atrial fibrillation, and we would predict we're going to see an epidemic of atrial fibrillation in the next few years ahead. Heart failure. 5% of New Zealanders will develop heart failure at some stage in their life, and we're seeing more people surviving heart attacks who then we've got to manage their angina. Management. We've talked today about risk assessment, cardiovascular disease risk assessment, and also the smoking assessment that we do when people come into hospital. But what do we actually know about management? Can I just ask, just out of interest in the audience, people over 50, how many people know they've had a cardiovascular risk assessment done by their primary health care physician? Of those people, how many have had a conversation with their primary health care physician about that CVD risk? So, okay, so not half of people over 50 and even less have had a conversation about what that actually means. That's not good enough. You know, we don't know what's going on when we are risk assessed. What's the conversation about? What does it mean for me? I'm an interventional cardiologist, so I have to show an angiogram. Sorry, so you'll have to indulge me. And this is a 55-year-old man with a heart attack who came in, had his artery opened, and stented him at home on day 3. So a nice acute management, appropriate acute management. This man was transferred from Lakes to us on a Friday. He went home on Monday. We met the target. Great. We met another, these targets are important. I was one of the drivers behind getting these targets introduced into New Zealand. And as you can see across our region, 2015 to 2016, we more often than not meet the ACS target, which is 70% of our patients with a high-risk acute coronary syndrome undergoing angiography within 3 days. But is it really optimal care for Will? Stuart, your thoughts? I pick you purposely here, Stuart.
There is evidence that quicker management would improve the outcome.
Quicker management would?
Improve the outcome.
Okay, all right. Your answer surprises me. So here's the point. So Will's come into hospital on a Friday. He's gone home on a Monday. He was on no medications before he came into hospital. Almost certainly we will have prescribed 5 medications before he goes home. We are setting Will up to fail. I've no doubt in my own mind we are setting someone like this up to fail unless we provide appropriate support in the community for someone like Will to look at secondary prevention. If you look here, and again this is data from ANZAC QI, look at the 5 medications. We've got variation in use of this therapy across our country. Southern has almost just over 85% of patients been discharged. South Canterbury on 5 drugs, quintuple therapy, as opposed to ourselves in Waikato, where we're around about 55%. So variation in what we would regard as standard of care on discharge. If we look at what actually happens when people go home, and this is data recently published, Andrew Kerr's the lead author on this, again from the ANZAC QI data set, where we're looking at aspirin and statins alone, so 2 of those 5 treatment options, 3 years post-discharge, only 59% will maintain an aspirin and statin, and 1 in 5 patients, 3 years post-ACS presentation, were on neither of those 2 agents. Okay? So why is that happening? We need to understand what are the barriers to optimal care, and we've heard about this today, translational research. We need to understand what's going on, why are we not applying the evidence to our patients post-ACS presentation. Cardiac rehab, and this was published earlier this year by Jeff Kira, Maori Heart Foundation fellow, looking at cardiac rehab. I'll just summarize it for you. Cardiac rehab's in a mess in New Zealand. It's delivered inconsistently, and there are no measurements done that are patient-specific. So if I've had my heart attack, am I back at work? Have I stopped smoking? What are the things that are important to me? So we need to do this better. Why? If you look at the consequences of not doing this well, I told you these patients make up 50% of the people admitted with acute coronary syndromes, but 1 in 5 will be admitted to hospital with a further acute coronary syndrome within 1 year. That is twofold so Māori and Pacific. Māori's twice as likely, and Pacific 1.5 times as likely as Pākehā had to be admitted. So we need to understand what's going on, why are we not optimizing care for our patients with the evidence-based treatment that we know actually works. I think ANZAC QI provides us with a great opportunity to do this. Someone comes in with their acute coronary syndrome here, they are entered into ANZAC QI in all our hospitals currently around New Zealand that admit people with acute coronary syndromes. The data is anonymised and linked to outcomes at 12 months. We can look at dispensing. And the intent of ANZAC QI, and this is a really important thing to emphasise, is the QI bit. Research, yes, important, but we need to demonstrate improvement in care for New Zealanders with this resource, which is supported by the Ministry of Health. So we need to understand the barriers to optimal care across the continuum and use platforms such as ANZAC QI to help us do so. Some thoughts about rehab and risk reduction. Is it time to rebrand this and re-energise it? Is the science challenge a platform for us to actually look at this? Education of the benefits, reducing the barriers to uptake of rehab, looking at different ways to deliver rehab around the country, efforts to increase coverage, and looking at performance measures. I think performance measures are really important with some of the things that we do, certainly around secondary prevention, and they need to be across the continuum, not just in secondary care. Most of these patients are in the community. We want to keep them in the community. We need to know what's going on in the community. So, final 2 slides. In New Zealand, and this is from the Ministry of Health recent publication, they stress that coronary heart disease still accounts for over 8% of all health loss. About 70 to 80% of this is potentially avoidable through prevention and treatment. And also, let's not forget about stroke. Okay? A lot of the drivers that cause people to present with heart attacks also cause strokes. So blood pressure management, cholesterol management, smoking cessation, really important we don't forget that. So I'll finish up there and just an advertorial for the Heart Foundation. This is what we do. This is our mission. We try to do it through the things that are better. They're better support, care, research and prevention. So thanks, Ricky.